Hello, future doctors. How are you all? Welcome back to MedSteps Internal Medicine series by Dr. Anand. So, right now we are in episode 5. Today, our topic is acute coronary syndrome. So, in our previous episodes, we discussed some important topics like cardiac conditions, like acute pericarditis in episode 1, in episode 2, valvular heart disease, in episode 3, atrial fibrillation, in episode 4, we learned about infective endocarditis. So today in episode 5, we are going to learn one of the most important emergency topics in cardiology, that is acute coronary syndrome. So chest pain is one of the most common presentations in emergency medicine, but identifying whether it's due to myocardial ischemia or can be life-saving. And acute coronary syndrome represents a spectrum of conditions caused by sudden reduction of blood flow to the heart muscles due to coronary artery blockage. So it includes unstable angina and NSTEMI and STEMI. So in early diagnosis and treatment can prevent massive myocardial infarction, heart failure, arrhythmias, sudden cardiac death. So these are the things we can prevent. So in today's episode, we will understand through this lecture pathophysiology of acute coronary syndrome and difference between STEMI, NSTEMI and unstable angina, and clinical presentation and how to diagnose that ECG, how to interpret that ECG with STEMI and non-STEMI, and how we have to differentiate, and cardiac biomarkers, immediate emergency management, or we have one concept we call management of MONA and modern ACS treatment, reperfusion strategies, and secondary prevention. So this topic is extremely high yield for internal medicine and rotation exams, or if you're preparing for any FMGE or NEET PG or USMLE, this is the best and important topic. So without time waste, let's begin. So, acute coronary syndrome, internal medicine series. A cardiovascular emergency condition includes unstable angina, NSTEMI, and STEMI. So, what is acute coronary syndrome? If you are seeing here, this is the definition of acute coronary syndrome. So, this acute coronary syndrome is a group of clinical conditions caused by acute myocardial ischemia due to reduced coronary blood flow. Okay, so usually it's caused by like atherosclerotic plaque rupture and reduced like thrombus formation, and it will cause coronary artery obstruction. So we have three different types of anginas. You can see here first one, unstable angina. Unstable angina, you can see that is like ischemia without myocardial necrosis. Okay, and the troponin will be like negative and no ST elevation. So the symptoms at rest with ECG changes, and you can see myocardial ischemia is not sufficient to cause myocardial damage. So, and therefore there is no rise in serum markers of myocardial injury, example troponin. So in simple, in unstable angina we can see only ischemia without myocardial necrosis. Means, for example, this is blood vessel. So in unstable angina we can see like very partial blockage. So the blood can flow from here to here. So because of low perfusion of blood, we can see sometimes the symptoms of chest pain in patient, but it's not that much life threatening. Okay, but no, we can't see any ST elevation, but troponin also will negative, and the ischemia without myocardial necrosis. Okay, next you can see here that is NSTEMI. NSTEMI means it's like same to same like myocardial ischemia, but here you can see sufficient to cause myocardial damage. So you can see little more obstruction. So because of the thing, the myocardial will get a necrosis and it will get damage, and we can see elevation of serum markers of myocardial injury. That means the troponin, if you are seeing troponin level will be like 0.04. So here what will happen, the troponin level will increase in NSTEMI, but we can't see any ST elevation in ECG. And in NSTEMI means it's like myocardial necrosis. Next you can see here, that is another one, STEMI. STEMI means it's like complete coronary occlusion. We can see like total ST elevation you can see here in ECG, and complete occlusion of coronary artery. That means, for example, this is blood vessel. In that blood vessel, the plaque will form like this, and it will obstruct. Okay, so the blood is not passing from here to here. So whenever the blood is not passing, then we call that is STEMI, ST elevation. So complete coronary occlusion and ST elevation on ECG we can see, and myocardial necrosis. So how to differentiate this STEMI and versus unSTEMI versus unstable angina. In unstable angina, the troponin level will be like negative, and the ECG we can see ST depression and T inversion, and occlusion will be like we can say partial occlusion, and necrosis will be like no necrosis, and that emergency will be like high emergency. Okay, because if you are not focusing, if you are not treating that time, it will lead to NSTEMI. So that's why. So next you can see here, in NSTEMI the troponin will be like positive. In ECG we can see same to same like unstable angina, ST depression and T inversion. The occlusion will be like partial, and you can see necrosis, and it's like a very high emergency thing. So last option, that is STEMI. STEMI means the troponin level will be like positive, and in ECG you can see ST elevation, and you can see complete occlusion you can see. Along with that, the necrosis will be present, and the emergency is highest. So that's why we have to do some percutaneous angiography, this type of things we have to do. Okay, so next you can see here little amount of epidemiology of acute coronary syndrome. So in epidemiology, this is coronary heart disease, the one of the most cause of death in United States, in the worldwide. Okay, United Kingdom. And incidence, this increases with age, and elderly people also tend to have higher rates of morbidity and mortality from their infection. Okay, so actually in normal coronary artery we can see the coronary artery will get adequate oxygen supply with blood. That is normal myocardial function you can see. But here because of like atherosclerotic plaque, or because of the coronary artery becomes strained or stiff or narrowing stenosis, so because of this thing we can see this type of acute coronary syndrome, that spectrum pathological conditions. Okay, next, pathophysiology. So in pathophysiology you can see here, next, pathophysiology, what are things will happen. First, actually you can see in pathophysiology the atherosclerosis have some several stages. First of all, atherosclerosis plaque will form. The atherosclerosis, the like plaque rupture we can see, and it will become erosion. Means first of all we can see endothelial cells. The endothelial cells, the lipid will deposit inside the intima layer of the coronary arteries, and together with vascular, then after it will cause vascular injury. So why vascular injury? Because of increasing more amount of blood pressure, because of hypertension, the endothelial will get damaged, the plaque will become rupture, and it will get erosion, and it will cause inflammation, and it will increase permeability and recruitment of white blood cells. Then it will get inflammation, time inflammatory cells, then particularly macrophages you can see. Then these macrophages will accumulate up the lipid and becomes foam cells. Okay, so next you can see here the platelet will activate and the thrombus will form. Then you can see partial or complete coronary artery occlusion with plaque formation. This is the main foam cells. It accumulates in smooth cells and it proliferates to resulting in the growth of plaque. So then after you can see the plaque will get rupture and it activates the clotting cascade and thrombosis. which might be sufficient to cause partial occlusion and resulting in myocardial ischemia and angina, or total occlusion resulting in myocardial necrosis and myocardial infarction and myocardial MI. Okay, so here whenever the blood vessel getting partial or complete coronary artery occlusion, it reduced myocardial oxygen supply and it will cause ischemia, and then after myocardial injury at last it will lead to myocardial infarction. Okay, so next we can see here that is risk factors. The risk factors, we can see some risk factors. In this risk factors we have some non-modifiable risk factors and modifiable risk factors. In non-modifiable risk factors we can see increasing age, male sex, family history of premature coronary heart disease, and premature menopause, and along with that another factor is there, that is genetic factors. Okay, next we have another factors, that is risk factors, that is modifiable risk factors. This modifiable risk factors, we have some major risk factors, that is smoking, diabetes mellitus, like dyslipidemia, and impaired glucose intolerance. Because of diabetes the blood vessel will become stiff, and you can see hypertension, then after dyslipidemia, then after obesity, then after sedentary lifestyle and physical inactivity. Okay, so these are the main risk factors can cause myocardial acute coronary syndrome. So next you can see here, that is main causes of acute coronary syndrome. That is most common cause will be like atherosclerotic plaque rupture. This is the main thing, atherosclerotic plaque rupture, or other causes also there, that is coronary artery spasm and coronary embolism and spontaneous coronary artery dissection and cocaine induced vasospasm. So these are the main causes of acute coronary syndrome. If any person getting like in young age, if patient getting any chest pain, means we have to suspect the patient taking in some cocaine or drugs, because it can cause induced vasospasm. Okay, so next you can see here, that is clinical features. In this clinical features you can see here, whenever patient coming with acute coronary syndrome, first symptom we can see, that is chest pain. First symptom will be like chest pain. In chest pain it's like typical angina, and we can see that pain will be like retrosternal, and it's like pressure, heaviness, tightness or crushing in nature, often radiates to arms, neck and jaw. Okay, so this is the typical that angina chest pain. Next we can see some associated symptoms like shortness of breath, okay, nausea, palpitations, sweating, and breathlessness, palpitations, anxiety, okay, and dizziness. So these are the main clinical features you can see. In some patients groups, like example elderly, diabetics, elderly patients, diabetics, females, and those with chronic kidney disease may have little or no chest pain and may be present with atypical features such as abdominal pain, altered mental status, or jaw pain, so called silent myocardial infection. Okay, so the atypical, we call that is atypical presentation. So silent MI, it will comes in atypical presentation of clinical features. Okay, so this chest pain, shortness of breath, it's showing symptoms, so we call that is typical presentation. So in physical examination, if you are seeing here, what are the things we have to focus on physical examination? In history we have to take proper assessment, proper history we have to take. After history taking, we have to take physical examination. In physical examination it may show like tachycardia, hypertension, or S4 gallop, or signs of heart failure, new murmur. If any blood, if any papillary muscles become rupture, it will cause new murmur. Okay, so thing is, whenever patient coming to accidental emergency department, how we have to identify this history taking, physical examination, how to do proper initial assessment. First, when patient coming to the accidental emergency department, first we have, if we are suspecting acute coronary syndrome, we have to go with primary assessment like A, B, C, D, E, airway, breathing, circulation, and disability and exposure. After that, we have to put the 12-lead ECG within 10 minutes. Then we have to check cardiac biomarkers and we have to start treatment. Next, you can see that is investigation. In investigation, you can see here, in investigation, first thing, that is ECG. ECG is the one of the most important initial test we have to do for acute coronary syndrome. In first one, you can see here, that is NSTEMI. Unstable angina or NSTEMI, it may be normal or it will show segment like ST depression and T wave inversion. That means it's like unstable angina or ST or non-STEMI. Okay, so in non-STEMI you can see ST depression and T wave inversion. Next you can see that is STEMI. In STEMI you can see here that is ST elevation and ST elevation or new left bundle branch block. How to find out, how to interpret these things in ECG? You can see here, this is normal ST elevation. This is normal, and here you can see this is ST elevation. In ST elevation, after P, this is Q, this R, and this S, and it will go like this. So this is ST elevation. If it's going like this, means that is ST depression. So you can see ST elevation in myocardial infarction. Okay, so ST elevation. Once it's going to days, then it will go to, it will change like ST elevation, and we can see pathological Q waves and inverted T waves you can see. Next, once it's going to weeks, we can see it's change in ST flattened off and pathological Q wave we can see more. Next, in months, you can see pathological Q wave will be like, it will grow more. So that is pathological Q wave. That means we have to suspect patient have history of myocardial infarction. Okay, so if patient have any bundle, okay, whoever have history of myocardial infarction, ST elevation, we can find that in that patient we can find left bundle branch block. Left bundle branch block. How you can find this left bundle branch of block means, it's like we have to check this V1 and V6. You can see this sign, this is W, 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 W. Okay, in QRS complex you can see wide along with the W, and V6 will be like, you can see that is positive axis. You can see here that is like M. So if it's like the V1 you can see W, and V6 you can see M. Okay, so that is left bundle branch block. In right bundle branch block you can see reverse. That means in V1 you can see M, in V6 you can see W. So that is the difference between this left bundle branch block and right bundle branch block. Okay, so next you can see here some of the blood test we have to do for ruling out for routine. Whenever patient admitting to the hospital, we have to do some routine test, that is like a full blood count for checking anemia, and urinary analysis to assess renal functions, and fasting lipids to check that risk of stratification of lipids, liver function test, and thyroid function test. Okay, so with the liver function test, if it's like baseline before starting statins, we have to check liver function test. Okay, next we can see here we have to for finding that cardiac function, we have to do some cardiac markers, that is first one troponin and other cardiac enzymes. So in troponin is the most specific marker. Okay, and it's like highly sensitive and specific for myocardial infarction. It's like normal in unstable angina. So in troponin, we can see I and I by T. Okay, so this troponin, if you're saying, means why we have to do this troponin test means whenever patient got any myocardial infection or unstable angina, low perfusion of the cardiac muscle cells, this troponin marker will rises within 3 to 6 hours, and it will be peak in 24 hours, and it remains elevated around 7 to 14 days. Okay, so that's why this troponin marker is very important. So this is very specific and highly sensitive test. And other cardiac enzymes also there, such as like creatinine kinase will also be raised, but this is less specific. Okay, and this creatinine kinase, like we called CKMB. This CKMB will rise, but it will take around it. Okay, for rising it will take 4 to 6 hours, and it returns back in 48 to 72 hours. So it will useful for detecting reinfection. Okay, because we can see here this troponin marker will be present for around 7 to 14 days, but since the CKMB, it will come back within 48 to 72 hours. Okay, next we can do that is chest x-ray. The chest x-ray will help to assess the presence or absence of heart failure, pulmonary edema, and exclude other diagnosis. Next we can do that is echo. This echocardiography is the main thing. It will help to detect regional wall abnormalities, along with that motion abnormalities, regional abnormalities and motion wall abnormalities. Along with that, we can see ventricular function, like left ventricular function. Along with that, if we can have any complications, we can easily find out. Okay, so next we have to do coronary angiography. What it means? Coronary angiography is the gold standard. It will show the site of blockage and severity of stenosis. Then this coronary angiography will guide us to do percutaneous coronary intervention. Okay, like angioplasty plus stent. Okay, so this is the thing. So next you can see here management of acute coronary syndrome. So in initial management, first of all we have to follow it. We have one traditional, that is initial treatment for all patients. We have to go with MONA. MONA means first one we have to start with morphine. We have to start morphine. The morphine will be like oral or intravenous. We can give diamorphine. Example like 2.5 to 5 milligram we have to give, and it can be given for pain relief. For an antiemetic such as metoclopramide should be co-prescribed with morphine. Okay. Next, O means oxygen. So oxygen also we have to give once the patient getting hypoxic, or if patient have any pulmonary edema because of heart failure, continuing myocardial ischemia, we have to give oxygen if it's going less than 94% of the saturation. Okay. Next, nitrates means nitroglycerin. This nitroglycerin is the main thing to relieve ischemic pain, and it's initially sublingual. We have to use example like 2 spray of GTN, and if it's not effective, we have to go with intravenous or buccal. Intravenous isosorbide dinitrate can be given. Next we have to go with aspirin. Aspirin, all patients should receive 300 milligram aspirin once the patient coming to accidental emergency department to achieve a SAP. Okay, so this subsequent management depends on whether the patient has unstable angina or NSTEMI or STEMI. So based on the thing, we have to treat that patient. And modern acute coronary syndrome includes like additional evidence-based therapies, like we can use some medications, and along with that, first how to do this management means, first of all we have to go with this initial management like MONA. Then after MONA, we have to check the patient have like STEMI or unSTEMI, unSTEMI or unstable angina. If patient have NSTEMI, we have to go with if patient have NSTEMI or unstable angina, we have to estimate 6M mortality. Example, we have to use Gray score. What it is? Gray score means Gray score means it's like global registry. Gray's full form is Global Registry of Acute Coronary Events. So it's a scoring system to risk stratify patients with diagnosed with acute coronary syndrome to estimate their in hospital 6 months to 3 years mortality. So it's based on 8 variables. What are the 8 variables? You can see here one is age, signs of heart failure, and heart rate, and blood pressure, and serum creatinine level, ECG changes, and troponin concentration, and cardiac arrest, and presentation. So with this Gray score, we are going to check we are going to do this risk assessment. Okay. So after seeing this Gray score, we have to divide into 2 different parts. One is low risk, that is less than equal to 3%. Next we have another one that is intermediate high risk. If it's low risk, we can go with we can give ticagrelor. It's like we can go with ticagrelor medication. Ticagrelor means it's like the class of drug will be like P2Y12 inhibitor. We can start 180 milligram loading dose orally. Then after we have to give twice daily. Usually like for 12 months we have to give. How long? 12 months we have to give, and it's faster onset than clopidogrel. So that's why this ticagrelor is the very best drug for unstable angina or NSTEMI in low risk patients. Okay, we can consider the clopidogrel also, but this clopidogrel also same drug like P2Y12 inhibitor. We can give like 300 to 600 milligram loading dose orally. Loading dose we have to give. Then after orally daily maintenance, we can give this medication for 12 months. Usually it's like faster onset than clopidogrel. So this clopidogrel we can use with the aspirin or aspirin alone for high bleeding risk. Okay, so next you can see here that is immediate high risk, like greater than 3% means we have to go with percutaneous coronary angiography. In percutaneous coronary angiography, to prevent another episode where we have to do percutaneous coronary angiography. In percutaneous coronary angiography, it's like for unstable angina and stable and unstable angina and NSTEMI, we have to do immediate angiography if patient is unstable. If patient is stable, we can within 72 hours we can do. If patient won't have any contraindication, we have to give another platelet prior to PCI, percutaneous coronary intervention, like prasugrel, or we can go with ticagrelor if not taking an oral anticoagulation from beginning. Or we have to go with the clopidogrel if taking an oral anticoagulant. We have to offer systemic unfractionated heparin. Heparin is anticoagulant medication. Anticoagulant medication is like weight, based on weight we have to give, like intravenous or subcutaneous based on protocol, and it's like acute phase duration only we have to use. The main indication to prevent thrombus extension. Okay, so next you can see here that is if patient have STEMI, what we have to do. If patient have STEMI, then we have to go with suitable for reperfusion therapy. Okay, if it's no, we can wait for some time. If patient have symptomatic, then we have to go with percutaneous possible within 120 minutes. So total we have 2 hours. Within these 2 hours we have to do proper therapy. So here we can start some dual anti-DAPT therapy. So DAPT therapy means what? DAPT therapy means it's like aspirin. With aspirin we have to use some P2Y12 inhibitor like clopidogrel or ticagrelor. So this is the main why we have to use this medication to prevent the stent thrombosis and recurrent myocardial infarction. So if patient have STEMI, if suitable reperfusion therapy we have to give, then after we have to start with PCI possible within 120 minutes. The main goal is to restore the blood flow quickly. Okay, so the main strategy we have here, that is preferred strategy if less than 12 hours of onset of symptoms. The options will be like we have total primary we have like primary percutaneous coronary intervention is preferred if available promptly. Okay, next we have thrombolysis. If PCI unavailable, then we have to go with thrombolysis. Okay, thrombolysis or fibrinolysis, both are same. So first we have to check how that percutaneous coronary intervention will work. So here you can see here, this is the main percutaneous PCI. We have to give another antiplatelet like prasugrel prior to PCI. If not already taken, we can start, we have to give oral anticoagulant, or we can give clopidogrel. Then we have to go with radial access. With radial access is preferred an unfractionated heparin with bailout glycoprotein 2B3A inhibitor we have to give, and drug eluting stent should be used in preference. Okay, so these are the things. So this is the percutaneous coronary intervention we have to do, go with radial access. Next we have to go with thrombolysis. If percutaneous coronary intervention is unavailable, then we have to go with this thrombolysis. So it's indicated if less than 12 hours of onset of symptoms of primary PCI can't be delivered within 120 minutes of time, then we have to go with fibrinolysis could have been given. So fibrinolysis means what are the medication we have to give. So in thrombolytic drugs we have some drugs like fibrinolysis we call thrombolysis, or alteplase, or retaplase, streptokinase, and tenecteplase. So this is the main mechanism will be like it will convert a plasminogen into plasmin, then after it will break the clot. So we have to give this antithrombin at the same time. Then after we have to follow the following procedure, and we have to give ticagrelor. Okay, then we have to follow like if patient have any contraindications, we have to avoid this thrombolysis, like contraindication like previous patient have any previous absolute previous hemorrhagic stroke, or active bleeding, or intracranial tumor, or recent major surgeries, we have to avoid. Okay, so this is the STEMI management. PCI along with that antiplatelet like thrombolysis, along with that PCI with DAPT medication. Or in unstable angina, we have to go with treatment like aspirin, or P2Y12 inhibitors like clopidogrel or ticagrelor, or anticoagulations, and statins, risk stratification, and early angiography in high risk patients. Okay, so these are things. Next you can see here some important things. In clinical symptoms, the patient symptoms consist with acute coronary syndrome with persistent ECG features like greater than equal to 2 contagious leads of 2.5 mm ST elevation in leads V2 to V3 in men less than 40 years, or greater than equal to 2.00 ST elevation in leads V2 to V3 in men greater than equal to 40 years. 1.5 mm ST elevation in V2 to V3 in women. 1 mm ST elevation in other leads. Okay, and New left bundle branch block should be considered new unless there is evidence. Otherwise, we have to focus. Okay. Next, you can see here in ECG how to find out where the patient have the clot and everything. So we have one with ECG. We have some leads. With that leads, we can easily find out where the patient have the occlusion. Okay, so in ECG localization of myocardial infection, you can see here we have lead changes. We can see first one V1 to V2. If V1 to V2, if you are seeing any ST elevation or ST depression on these things, we have to suspect the patient have subtle affected myocardial subtle affected area. The main artery will be like proximal left anterior descending artery. Okay, so next we can see V3 to V4 means that is anterior like LAD, left anterior descending artery, we also known as widow artery. Okay, so next we can see here that is V5 to V6. V5 to V6 means it's like apical, distal LAD and lateral circumflex and right coronary artery. And next we can see that is like lead 1, AVL and V5 and V6. We can see that is lateral wall and left lateral circumflex artery. Next we can see lead 2, AVF and lead 2, 3 and AVF. If you are seeing means that is inferior part of the myocardium, and 90% of right coronary artery and 10% of lateral circumflex artery. If you are seeing anything like V7 to V9, you have to suspect patient have posterior wall of myocardial heart problem. Okay, good. So these are the things. So this is ST elevation. You can see here 1, 2, 3 and 4. You can see. So and patient have mostly this type of anterior septal elevation. You can see. So anterior septal, how I'm telling this ST elevation in V1, V2, V3 and V4. Okay. So these are the main risk assessment, and another score we have that is TIMI risk factor assessment. It will help to risk score for unstable angina and NSTEMI, estimated mortality for patients with unstable angina and NSTEMI. Next we have another score that is heart score based on that major cardiac events, predicts the 6 weeks risk of major adverse cardiac event like greater than equal to 21 years old presenting with symptoms suggest like acute coronary syndrome. We have to go with this heart score, that is history, ECG, age, risk factors and troponin. Okay, these are the things. Next, in long term treatment, we have to focus on smoking, non-pharmacological management we have to do, because these are the main things will cause acute coronary syndrome. So here in non-pharmacological management, we have to do smoking cessation and weight control. Then after take diet, like proper diet and the style diet, and like if patient like hypertensive, dash diet we have to take. And exercise, it's very mandatory, 20 to 30 minutes per day until slightly breathless. Refer to cardiac rehabilitation, we have to refer. Next, driving. If treated successfully by coronary angiography, group 1 driving may recommends after 1 week. If not successfully treated, driving recommends after 4 weeks. The sexual activity may resume 4 weeks after uncomplicated MI, and prostaglandin inhibitors like example sildenafil they have to avoid, can't be used for 6 months after MI. Okay, we have to, the patient must be have to avoid this type of like nitrates and nicorandil, this type of medication they have to avoid. Okay, so in pharmacological management, we already discussed about dual antiplatelet therapy. In dual antiplatelet therapy, you can see aspirin 75 milligram OD lifelong. The patient have to use, and other antiplatelets like ticagrelor or prasugrel or clopidogrel for at least 1 year. The patient have to use, and we have to consider co-prescribing and proton pump inhibitors for gastric protection because aspirin can cause gastric problems. Next, we have to start ACE inhibitors or ARBs and beta blockers for bisoprolol or carvedilol or metoprolol for reducing blood pressure and pulse. If contraindicated, we can go with calcium channel blockers like verapamil or deltazim. And statins, high dose atorvastatin we have to start when patient admitting 80 milligram, then slowly we have to reduce in 1 month. Next, aldosterone antagonist, example like epleron for patients who have had an acute myocardial infection, evidence of heart failure, and left ventricular systole dysfunction. We have some typical contraindications we have for fibrinolytic therapy, like previous hemorrhagic stroke, ischemic stroke in the previous 6 months, central nervous system trauma, neoplasm, or recent less than 3 months major surgery, head injury, major trauma, and active internal bleeding or GI bleeding with last month, known or suspected aortic dissection, and known bleeding disorders. In relative will be refractory hypertension, transient ischemic attack 6 months, oral anticoagulation treatment, and pregnant less than 1 week postpartum, traumatic cardiopulmonary resuscitation, and active peptic ulcer disease. We can see advanced liver disease and infective endocarditis, previous allergy to fibrinolytic drugs. Okay, so these are the things. Now we can see some complications of acute coronary syndrome. That is, we have the complications. The mnemonic will be like Darth Vader. Darth Vader means that is like death, cardiac arrest, like most commonly occurs due to patient developing ventricular fibrillation. So in complications, we can divide this complication into 3 different parts, that is electrical, mechanical, and other. Electrical means we can see ventricular arrhythmia and atrioventricular block, okay, and cardiac arrest. In mechanical, we can see papillary muscle rupture, okay, and ventricular septal rupture or free wall rupture. In others, we can see heart failure, cardiogenic shock, and pericarditis, okay. And in cardiogenic and cardiac tamponade and ventricular aneurysm, Dressler syndrome and thromboembolism, okay, and rupture. So this and regurgitation. So Dressler syndrome means it tends to occur around 2 to 6 weeks following myocardial infection, thought to be autoimmune. So if patient have cardiogenic shock, what we have to do? This is the main complication we can see in acute coronary syndrome. So if patient have cardiogenic shock, the large myocardial infection, you can see the main features of hypertension and cold extremities, altered mental status, pulmonary edema, and for management we have to do ICU care, revascularization, and hemodynamic support. Okay. For secondary prevention, we have to do the lifestyle modification like smoking cessation, exercise, weight control, heart healthy diet, and medication the patient have to use like aspirin, statins, and beta blockers. The patient we have to use statins and beta blockers. These are the medication the patient have to use. Okay. Next, we can how to do follow up means we have to monitor the symptoms, ECG, lipid profile, and blood pressure, diabetes control, and liver function and left ventricular function. So in exam point of view, we have some important things in acute coronary syndrome. The most common cause of acute coronary syndrome for exam point of view, like in ASCII settings, they're going to ask these questions. So most common cause of acute coronary syndrome, that is plaque rupture. Most specific biomarker is troponin. Earliest investigation is 12 leads ECG. And STEMI means ST elevation and complete occlusion. Non-STEMI means troponin will be positive and no ST elevation. Inferior MI means leads, we can see 2-3 AVF will be elevated. Most common cause of death will be in early after MI, that is ventricular arrhythmia. Because of the death, the cell died, so it can't pump properly. So patient will get definitive STEMI treatment will be like primary will be like percutaneous coronary intervention. Okay, so these are the main things. So whenever patient is coming, what are things we have to follow? First, if we are suspecting coronary patient have acute coronary syndrome, we have to do ECG and we have to check troponin. Then after we have to patient have ST elevation, then we have to go with primary percutaneous intervention or thrombolysis. Like if you don't have uh, opportunity to do percutaneous coronary intervention because of some busy schedule, we can go with thrombolysis. Or if patient don't, the troponin is not positive, then we can go with NSTEMI management like MONA, Bush management you can go. Okay, so all patients aspirin, antiplatelet therapy and statin risk modification we have to do. So mostly I covered everything about acute coronary syndrome. So if you have any doubt, you can ask me in comment section, and I'm in Telegram like MedSteps YouTube channel. In Telegram you can see MedSteps channel, and in Instagram you can see Dr. Anandjana. Okay, so this is my platforms. You can message me if you want to reach me. You can message me through that platforms. And if you this video is useful for you, you can like, share and subscribe. If you have any doubt, you can ask me in comment section. So I'm signing off by your Anandjana. So till that time, for next video, for upcoming video, we are going to discuss about heart failure. Okay, so till the time, take care. Bye bye.